Good afternoon, everyone, and welcome to Gateway Foundation's virtual Recovery Month panel. Thank you so much for joining us. We're happy to be here with all of you today, and it's my pleasure to welcome everyone who's on the panel and those of us who are listening. I'm Dr. Teresa Garate. I'm the Senior Vice President of Strategic Partnerships and Engagement for the Gateway Foundation, and I'm happy that today I'm being joined by my boss, Dr. Tom Britton, and our partners in the community to have an important conversation. September is Recovery Month, and while we always talk about recovery, at least the people on this panel, we know that it's important to remind everyone in communities and societies that we should always be focused on recovery. Mental health and substance use issues are very critical, and before the pandemic, they were the #1 public health issue of our time. So today I'm very excited to bring together partners in the community. So really we want to highlight that this problem needs to be addressed by multiple sectors. So we have a rural health hospital president, an urban hospital president, a partner from Will County Health, and a leader from the Illinois Board of Higher Education. And the idea is that they will share and answer some questions together today to show how we need to work together. It takes a village to do the things that we want to do. So with that, I'm going to ask the format's going to be, I have a set of questions. I'm going to ask Dr. Britton to start, but as I go through each question and ask each person to respond, if you could also introduce yourselves, tell us a little bit about who you are and why you're on the panel today. For those of us listening to us, please feel free to put comments. We have our helper in the background, and she will share those comments with us. With that, Dr. Britton, would you like to introduce yourself and also tell us why you think it was important for Gateway to pull this panel together during Recovery Month? Sure. And Teresa, thank you so much for your energies, and thanks to this great panel for joining us today and talking about recovery. It's such a critical thing. So I'm Dr. Tom Britton. I've been in the field of behavioral health for 30 years now, which is weird, how much time goes by. And I have the extreme privilege of supporting the Gateway Foundation and our mission nationally. We're the largest not-for-profit provider of substance use treatment in the country. We serve 8,000 people a day right now, which is just remarkable. For 53 years, we've been helping people who suffer from substance use disorders find a new way to live, looking at the problems that they've been living through and finding kind of a future that is free from substance use. And, we have known for all those years how possible recovery is. As a person in long-term recovery as well, this is very personal to me. And I'm, literally a living example of somebody who asked for help and was given help. And therefore I'm sitting here instead of all the places I could be. It was just such a miracle. And we've helped literally over 1 million people since we opened our doors to work towards finding a new way of life. We're living in a time today where substance use is more deadly than it's ever been. If we look at the last 5 to 10 years, the number of people who've died from overdose has gone up 20 to 30% every year. Last year was our highest number ever. 100,000 people are known to have died of an overdose, and most likely more. And so the stakes of getting into recovery, getting into treatment, getting overdose reversal drugs is more important today than it has ever been in our history. And the most important takeaway I hope people have from this is that there's hope, that there is treatment here and that life can be changed. And, with that, Teresa, I know I'm going to speak later. I'll turn it back to you for the panel. Thank you all again. Thank you, Tom. I'm going to invite Ginger Ostro for the next question. Chair Atkinson was going to join us, and he sends his apologies, but we have the executive director of IBHE, so she's going to do a great job. Healthcare centers were hit very hard during the pandemic, but probably the next mostly hit hard group of institutions were schools, K-12 schools, institutions of higher education, the entire educational system, with children as well as adult students, young adults having to learn from home. It was very difficult for them to do that, and very stressful for faculty and staff as well. Ginger, I'm wondering if you could share a little bit about kind of the experience, what IBHE did during the pandemic to support the faculty and staff, the students, and also what people should be thinking about for the future of higher education, and anything you want to share from that perspective.
Great, thank you very much. Thank you so much for having us and having the Illinois Board of Higher Education represented in this really important conversation. We're really grateful for the opportunity to be here. And for the great question. I think just really recognizing the impact that the pandemic has had on our colleges and universities, it is maybe not something that comes to mind immediately for folks, but when the pandemic first hit and our public and private institutions across the state, community colleges all had to pivot immediately to remote learning, and students had to, head home or stay home, and really address some of the big challenges they had. A couple of the things that the state was able to do, and I didn't mention, the Illinois Board of Higher Education is the higher ed entity. We're a state agency responsible really for coordinating higher ed in the state of Illinois. And in that role, we heard right away from students in particular and from our academic leaders, just the pressure that students were facing and the challenges. And so even before the federal government stepped in to provide the federal relief dollars, we raised about $700,000 in private funding to provide emergency grants to students. And they covered the gamut from helping to address technology needs, but also to really addressing some of the basic needs that students were facing just around housing security and food. And all of those are obviously incredibly crucial. And then as the federal dollars became available, we made sure that institutions that serve students with greatest needs had access to even more dollars through the money that came through the state. And I think just to share with you, I think how important that is, and you all know how integrated this is, but some of the quotes that we got from students that received these grants were things like, "This grant helped me mentally, physically, and emotionally. I went from being on the probation list to the dean's list. I'm very appreciative of the stability that this grant offered me. Thank you very much." I mean, that kind of comment, you just really realize how every piece of support is essential. And then obviously the institution stepped up to add mental health services, make sure counseling services were available. And there's so much more that we need to be doing going forward. So I could keep talking for minutes and minutes and minutes, but I won't. But that just gives you an idea of what had to happen right as the pandemic hit, and then those services and resources that have continued as we've gone throughout, because clearly the impact hasn't declined or decreased.
Thank you, Ginger. I'm going to turn to Karen Teitelbaum now. Karen, you lead one of the lead safety net hospitals in the Chicagoland area. You've been dealing with mental health and substance use issues for a long time, or your hospital has. But well, maybe you too. Sorry. Hey, no shame. It's right? That's what we're all talking about.
It would be okay. Yes.
So could you share a little bit about kind of how Sinai responded during the pandemic and what you saw specifically around the needs for mental health supports and addiction supports in the communities that you serve at Sinai?
Well, thank you, Teresa. And I do want to thank Tom for his very personal opening, because at the end of the day, I think that brings us back to why we're all doing what we're doing. So thank you, Tom. So, obviously stats that we all know. I think that the Chicago Department of Public Health put out that there was a 72%, I found this like stunning, spike in calls dealing with opioid overdose. We know that there was a 26% increase in overdose deaths. And I just read somewhere that 13% of all adults reported, and I was surprised it was this low, reported increased use of alcohol or drugs during the pandemic. So clearly that all played out, throughout our communities. And let me talk though about a community that's a little bit closer to me, which is our employee community, and what we needed to do and provide for mental health services during this time. As you can imagine, these were the front line. We are the largest employer west of Western, with over 3,200 employees as Chicago's largest private safety net. And we just saw our team showed up every single day, but under tremendous amounts of stress, and we were concerned about the toll that was taking. So we looked at and put into place increasing behavioral health presence from our own departments to be located in departments for ready access. We, of course, have our EAP. We increased our chaplaincy presence throughout. When people are in this time of crisis, they're showing up for work, but they're bringing all the stress from home with them. We also did a lot of support with regard to childcare, elder care, the kinds of things that add to that stress that ultimately could result in increased substance abuse use. We even had at some point a laundry service given by a donor that was picking up, so that when our folks went home, as the donor said, the last thing that he wanted them to be worrying about was having to do a load of laundry when they had gone home after taking care of our community. And then we really did partner quite a bit with our the experts who are our closest partners in the community, like Haymarket, in terms of referrals, our shared patients in the community. There's an expertise there. Again, I'm going to go to Haymarket. There's an expertise there that is deep and a longstanding relationship. And we were seeing our community so hard hit that was a very, very valuable partnership. During this time, we also did open up an inpatient substance abuse unit, alcohol and substance abuse unit at Holy Cross. But that's kind of brand new for us with US Health Fest.
Thank you, Karen. That's very helpful. And I'm glad you shared some of the statistics. I think it's good to remind everybody of why we're talking about this during September and continue to focus on recovery. Teresa Rutherford, you and I have not actually had the pleasure of meeting, I don't think, but HSHS has been a wonderful partner over the last year. We actually enrolled 5 hospitals during COVID in our warm handoff model. So I'm so happy that you could join us and represent the rural communities. And if you could talk a little bit about, both as a critical access hospital leader, what have you seen change in your hospital around mental health and substance use during the pandemic? And then also, we know that mental illness and substance use are viewed different in different communities. And so if you can talk a little bit about kind of, what you're doing in your communities to end some of the stigma around this topic. And thank you for being with us.
Thank you. So as Teresa said, I currently lead St. Mary's in Decatur, and prior to this, though, I was in a more rural community in Effingham, and every health needs assessment I have ever seen comes across with behavioral health and substance abuse as being needed interventions, and irrespective, but how we handle it, I think, looks a little bit different. Of course, in more rural communities, it's more difficult to come across with a psychiatrist and even sometimes the advanced practitioners that can help support. In Effingham, we use a lot of telehealth. We had been recruiting for 8+ years and finally decided that telehealth was a way to work and collaborate with a mid-level practitioner, but it helped our behavioral health patients speak with a physician. It helped to evaluate medications, especially when they might be on multiple medications, not only for their behavioral health, but due to other illnesses that they might have, and how that all comes together for them and access to that. Also working with Catholic Charities to assure that they could get the medication once behavioral health had helped them establish what those meds might be. It doesn't help to have a med order if you can't afford the medication. So definitely that community collaboration, I think, is a big deal. It's a big deal regardless of where you are. And I appreciate the work that Gateway does because now being in Decatur, we have 3 inpatient behavioral health units. We have an adolescent unit, we have an adult unit, and we have a gero unit. And they have all been full. Lots of holds in our ER. I think it remains an issue for people with a co-diagnosis where they have not only a behavioral health issue, but a chemical dependency of some sort to go along with it. Placement for them becomes much more intense. It's not unusual for us to end up with someone sitting in our ER for us. The one that we transferred this morning had been here with us 5 days waiting placement. So I think placement, telehealth, access to providers that are experts at that can work alongside the primary care providers who try really hard to do everything that they can, but where this may not be their area of expertise, I think is pretty critical. broadening our scope to handle dual diagnosis. Also looking though at how do we handle it on weekends and after hours? And, that's when often our biggest challenges present. I think COVID, the pandemic, made us aware of more intense crisis for people. And what we are seeing is we are seeing a much greater number of young people, post-college level education, very educated people, but who are struggling to get positions as they come out into the workforce. And then on the other hand, for us, we struggle to fill our workforce within the hospital itself and within the communities that we serve. Many of our businesses have signs, please treat our colleagues nicely because we are trying to recruit. We as a healthcare facility, I have over 110 positions posted right now. So as Karen spoke about what they had done to handle the stress for their colleagues, I think that continues to be a huge issue for all of us. They have been so brave and so heroic throughout this entire time, but now we're working on year 2. And they thought this would go away, and we just went through another surge. And they've been strong up to this point, but now they are tired, and many of them are burnt out. And we are seeing behaviors and trends in them that would have never been part of their previous demonstration. But now even they are under the struggles of this pandemic. And I think behavioral health needs has become something that we saw outside of us and something we cared for. And more of it is something that our colleagues and people we work alongside need intervention for. And I think it's really about how aware are we and how verbal are we and what help can we get for people. As never before, I've seen people say, I've had enough, I can't do it anymore. Here's my badge and today's my last day. That's not the way healthcare providers transition their role. It never has been. But now behavioral health, and I believe, and for many of them, substance dependence is becoming more and more visible in their lives. And they're at their own wits' end about how they handle it. So those our caregivers are becoming those that need the care as well as the patients that put their trust in us.
Teresa, thank you. And thank you for sharing those very difficult stories to hear. We see that as well, as Gateway is also a healthcare provider. So, you talked a little bit about telehealth, and I think we could all agree that one of the silver linings of this entire thing is that we've all boosted the way we provide access to treatment and using telehealth. I think a lot of people didn't know, we've had telepsychiatry, but for the work that Dr. Britton and I do, we could never do virtual outpatient programs, right? That was not something that was allowed or we could get paid for. So there's a lot of innovation, and he's going to address that in a minute again. But, Dr. Burke has been a great champion at Will County and a great partner throughout the years to Gateway, but especially during the past year. And she's been very innovative, great ideas always. So wanted her to share a little bit about what they're doing in Will County and what she's learned from those experiences around coming up with innovative ways to address the recovery for all, the pandemic and everything that's happening around the increase of substance use issues. Dr. Burke?
Thank you. My role in Will County is Director of Substance Use Initiatives. And in that role, my job is to find out if people are able to access resources, if we have enough resources within the community, and how best to strategize and figure out how to remove the barriers to care. We're in the middle of an opioid epidemic. 5 years ago, we started working with the state of Illinois. We were funded to be able to identify what our barriers were. In Will County is very large geographically. I found that out right away when I started working here. You can put a lot of miles on your car when you're going from one community to the other. And it was my job to touch base with all those communities, which are all different. We're a rural community. We have farmers. We're an urban community. We have a center in Joliet. and Bolingbrook that are very urban, and that requires different responses to different challenges within those communities. Our best way that I found to focus on how to do this is through our partnerships. Through our partnerships and our agencies that are within our community, we can collaborate and we can talk about what is it we can do better. How can we provide this access to care? We had a shortage of behavioral health providers, both agencies as well as folks to staff those agencies. And it hasn't gotten any better. The COVID has actually exacerbated that issue. And given that we do not have enough behavioral health providers or services, we had to come up with alternative ways of getting people connected with care. One of those ways is what we have as a recovery coach training program. So I approached it from the other end, rather than the therapeutic end. I approached it from the long-term recovery end. How do we best keep people connected to services? How do we best keep people getting their lives back? And during COVID, the isolation that was created because of their inability to access their normal support systems was crucial in identifying that and trying to find an intervention that was going to prevent people from relapsing. The industry saw a large number of relapses during this time because we took away the support systems. We took away the people connection that was so valuable and was a lifeline to many people. Recovery coaches are actually individuals who are trained to help people continue their long-term recovery. So you have treatment facilities and you have outpatient care facilities and you have programs. Recovery is a lifelong experience. It doesn't end at the end of a certain period of time. And what was important is that we created space for people to get assistance with that long-term journey. Particularly with opioids, medical assisted treatment came along, which was an innovative, very remarkable way of helping people who had an opioid addiction stay in recovery. Well, that was met by the community in some cases, not in a great way, in a negative way. And so education to both the client, the patient in recovery, and the community is critical. And so our recovery coaches are now placed in all of the behavioral health agencies in Will County. They're through a grant through the Department of Labor. We're able to pay these folks in order to staff the agencies. So when two of those are in our Gateway program. And what was really nice is that people got smart about, they didn't want to lose these recovery coaches. So the phone became a huge lifeline to people. We could have them working from home and still connect to all of the agency's clients, which gave Gateway the resources they needed to be able to create that touch, and also the help that the clients needed to maintain their recovery and to gather the resources they need to continue getting jobs, finding places to live, all the things that people need to do to launch their life.
Go ahead.
No, I'm a huge advocate for a continuum of resources for people. And so that's what we've been trying to do in Will County. Sorry.
Thank you, Dr. Burke. Sorry, I didn't mean to cut you off. I thought you were done. My apologies. Dr. Britton, you've been on the news talking about the companion crisis like every week. Can you talk a little bit about kind of what you see the future and why people are not accessing treatment now? They didn't before either, or less people didn't access than needed it. But talk a little bit about what some of those challenges are to access, barriers to access, and what we're doing at Gateway to try to address that.
Sure. And I think that obviously could be a long conversation that each of us could really provide some good lens on. But at a high level, what we know is there's 26 million people in the country that meet a clinical diagnosis that requires treatment. There's an additional 60 million or so that are using substances problematically. So you've got 85 million people or so who would benefit from clinical intervention. What we also know is that only about 10% of people get treatment out of that 26 plus million, group. And the reasons for that are really complex, but there's kind of two lenses to it. The first is really stigma remains a huge barrier for people in entering care. That, I correlate it to, if one of my sons had, type 1 diabetes, I would have absolutely no concern about getting him care. I would fight to the death. I would fight with the insurance companies, and, pretty much everywhere they'd be like, how sad, I'm so sorry your son has it. Is there anything I can do to help? And that's a generally accepted thing. People with chronic diseases are not scared to ask for help. Where substance use, also a chronic disease, that there's a lot of shame, there's a risk of retaliation. We live still in a kind of punishment environment for substance use, that I can go to jail, I can lose my job, I could lose my, license, my medical license, or my, legal license, or whatever. And so part of the effort that we need to do as a country, as providers, and as people, is to shift the conversation about that. That substance use is a medical condition, it is a lifestyle disease, it is a chronic disease, and that there's nothing wrong with asking for help. On the other side of the coin is that when people want care, they have a really hard time getting care. And there's really kind of two worlds. There's the world of those that, and really kind of three. Those that have a lot of economic means, they can pay out of pocket, and their family members can go anywhere in the country at any point on demand, and they can get lots and lots of care. In the middle are those with commercial insurance that, can get pretty quick care, but the insurance companies manage and try to shorten the care. And then those with public insurance or no insurance, there's very little access to care. And so we need a large social, change. We need a government, we need an employer and a payer investment into really thinking about substance use as a continuum, as a lifestyle process. And that requires an episode of care. So rather than 2 or 3 months of acute care, it's really about the care management piece. As Dr. Burke talked about, is that I can't just walk into the emergency department, for example, at Sinai, get treated for a heart attack, walk out, and never do anything medical again, or else I'm going to die sooner or later. And so, this is really a complex shift. What Gateway's doing about it specifically is really a host of things. But one of the things we're doing, as you talked about, is we're staffed in I think 25 hospitals in the next week or so in Illinois, where we are, really meeting people when they present with an overdose or substance use crisis. So that's one way that we can join with them, and before they just go home, we can help kind of direct them into treatment. In jails in Illinois, we meet with people with opioid use disorders. We give them medication that helps them to not use for the 3 days, after they leave the jail, really, again, in an effort to kind of reintegrate them into society. That we're expanding our technological way of joining with people using virtual means, where we're now doing 20,000 virtual sessions a month with people that don't have to physically come into care. That's going to totally change access to care in this country as we begin to expand that. And so I'm really excited about the future and what I think our opportunities lie. I'm very, very pleased that from the president to the governor to the mayor, that there are proclamations and recognition about Recovery Month. Like, we are making so much progress, but we can't live in a world anymore with overdose. Overdose is preventable. Every single one of them is preventable. We know the intervention that works. So it's time that we used it. Thank you, Teresa.
Thank you. Thank you, Dr. Britton. Yeah, I want to go back to education a little bit. Those of you who know me know that I'm actually an educator by training, but I've been in healthcare for the last 12 years or so. So I think it's perfect. Public health and education really go hand in hand together. If you're doing great public health, you're working with your educational system. So Ginger, obviously you represent higher ed, but you've been in education for a long time. And I think our educational system is broad, and some of the work that the state's been doing really is about a whole public education agenda. Can you talk a little bit about kind of what is the messages you want to give to people involved in the education system as students and faculty and staff come back? Karen and Teresa both talked about the stress on our healthcare providers. I think our educators are feeling the same.
Yes, thank you. I want to pick up on 2 points. I want to pick up on a thread that I heard in some of the other comments, which is about the workforce shortage. This is not starting with the answer to your question, Teresa, but I think something that's really important that the state is doing, because I think kind of recognizing what we do from what we can do from a macro and a policy level is important. And education, in particular higher education, kind of has 2 parts of what we call the P20 continuum from pre-K through post-secondary. We both educate college students, but we prepare the workforce. And you've all talked about the shortage of behavioral health workers, kind of all across the spectrum. So I do want to highlight just one of the things that the state is doing, which is as a result of a task force and legislation, created and identified one of the public institutions to serve as a behavioral health workforce center, to be a hub to partner with the other institutions in the state to really recognize what our needs are and to help build that behavioral health workforce that you talked about, where there's such incredible shortages. So that's something that's launching right now. We've just begun to partner and to build out that hub and spoke idea to really figure out what we need. And that's a partnership between the Illinois Board of Higher Education and the Illinois Department of Human Services and a number of the divisions within DHS. So I think some good work from the state, some really a lot of good foresight there in terms of what's needed. Still going to need long-term funding to support that, but to begin to build that consortium, to begin to build those partnerships to make sure we're building the workforce. I think that's one piece. The second piece that I really want to highlight is the recognition all across that, again, P20 spectrum from pre-K through post-secondary, of the needs of students, teachers, faculty, staff throughout the system. And the state has as a group called conveniently the P20 Council that brings together folks in the education community, not just educators, but advocates, experts, and others. And last fall, starting last fall, the group spent probably about 4 or 5 months just really asking this question: what do we need to do around learning recovery for students coming back to school or returning into in person? And also, what do we need to do for social emotional supports? And those were the two areas of focus. And as a result of that work, the state published what's called a learning resource guide. It's available online. I'm happy to put in the comments or chat the link to that. But it identifies a whole series of best practices, things that are in place that schools, early childhood providers, schools, school districts, and higher ed institutions can use to help make sure that they're really focusing both on what students need and on what the educators and the staff need in order to survive and thrive as we we've gone through, and then really hopefully come out soon the other side of the pandemic. And there's chapters specifically in this resource guide around behavioral health and counseling and access to academic advisors and counselors for students and what that looks like. There's a specific focus on mental wellness, trauma-informed practices and how we embed those in education. Cultural awareness and how we focus on, again, educators and staff going through this. So lots of work there. And I think it's also important, the kind of third area that the state has been focusing on is how the resources are allocated. And so as the state, I mentioned a little bit earlier, we raised some private money, but as the federal relief money has flown both from to the state through the fund that the governor manages, the Governor's Emergency Education Relief Fund, as dollars have gone directly to school districts through the State Board of Ed, or directly to institutions of higher education. We have been focusing them on focusing those dollars and through the Learning Renewal Guide, really on saying what can we do again to address learning recovery, but knowing that companion to that is social emotional supports and mental health supports and trauma support. So really bringing those two pieces together and saying this is the priority for those dollars that you are getting. How are you using them? And then just the final piece of that is for some of those dollars did stay centrally from the state to be able to set up some statewide initiatives. So partnerships with mental health services, money to go out to communities for community partnerships with school districts. So a number of initiatives that the state is funding through the federal dollars specifically focused in these areas. So I think, Teresa, you're right. There's just incredible overlap between what's happening in education and public health because it is so much, it so comes together and what we're seeing and the trauma that's impacting our students, their families, and our education community.
Thank you, Ginger. So I have Karen next. And Karen and Teresa, I'm going to ask you both the same question. Is you both alluded to, my next question was going to be about partnerships and linkages, but you both alluded to those. So maybe share a little bit where you see some of the gaps are? You know, like you talked about strong partners in the community around identification of needs, but there are still gaps. If there weren't gaps, we wouldn't be having this conversation right now. So can you share a little bit where you think the gaps are and how some of these resources are coming into the state, into the counties, into the state, into the schools can be used to close those gaps?
Well, yeah, I mean, there have always been gaps, right? And COVID really has, as one of our panelists said, exacerbated that. And we know at Sinai from our community members that chronic behavioral health, chronic substance abuse, let alone the effects of COVID, are just inextricably linked, obviously bad health, but also poverty, unemployment, and all the things that are just that cycle, right? So in my mind, the gaps would be sort of a holistic approach to how we go through this. And that's one reason why I'm so grateful for our partnership with Gateway. And we've got many partnerships, but we can't be everything to everybody, right? And the sheer magnitude of the expertise and the accessibility, which is such an issue for the communities that Sinai Chicago serves. The accessibility, again, I'm going to use Gateway as an example of your programs, is critically important when we need to share patients, when we need to coordinate care, when we have community members who have need of those services to be able to get stabilized, to be able to get back to health. So, you know, beyond having partners like Gateway to fill in that more of the clinical, we looked at partnerships that also help with housing. You know, people need safe and reliable places to live. Much easier when you're employed, right? So it's all of this, in my mind, all of this is linked together. So our partners in housing, like Southwest Organizing Project, that's just one example. North Lawndale Employment Network, focusing on getting people to work. And we all partner together in this. Even issues such as immigration. That's also, you know, frequently we haven't even talked about that today, but we serve, for example, Pilsen Little Village, and that community frequently needs services, but again, can't access or doesn't know how to access or are afraid to access those services, especially during COVID, when so much of the living conditions were a challenge. And again, this is where I'm very grateful to Gateway, because we know you have such a widespread, such a big footprint, that we know we're going to be able to get our communities for those services. We're going to be able to get our communities in. And just one other comment, and then I'll turn it over to my other hospital colleague. One of the things that's encouraging, even though it's supposed to be addressing a gap and will be addressing a gap, is the state support of transformation collaboratives. The state for Medicaid enrollees, but also to address the bigger communities, is supporting financially a number of different collaboratives throughout the state. Sinai Chicago is participating in a South Side Collaborative and a West Side Collaborative, where we're looking at how do we keep people healthy where they live. But again, this is where for mental health, substance abuse, it's way more than hospitals at the table, and there's a lot of community input as well. And in the past, you know, in my mind, that's been a huge gap, and I'm encouraged that many different providers, plus the community, are coming around the table in partnership with the state to begin to set up models that will address these issues.
What a great segue, Karen. So thank you. I agree. I think much of what we're very lucky to have as much collaboration as we do, but I still think there are gaps that set in the outpatient environment that, you know, unfortunately, it's often where there's not a lot of pay for service, or where certain insurances or our federal and state coverage is limited. So people have a hard time once they come out of an acute care setting, be it for behavioral health or otherwise, maintaining. And I think the collaboration in the community is what's going to help that. I think there's great opportunity to do more of that. We had a couple of sheriffs ago who saw a great need to help with substance abuse so that we could keep from putting all of our young people behind bars. That wasn't really the view he wanted of our community. And he really helped with some development of our FQHC and part of what they can do here within our community itself, particularly around substance abuse. And we're fortunate to have that, but realistically, it's still not enough. There still isn't enough coverage there for the number of people we have. And that's not only within our own community, but people who travel or can't get services within their own, who end up in our emergency rooms or seeking dramatic service during crisis. I think ongoing collaboration with our police, they're often the first that interact with these people who have had some sort of an overdose initiative. So our willingness as healthcare providers to provide them with Narcan and other things that can help save a life and maybe open a door for what that recovery can look like to start. If we don't stop and slow the amount of overdose and death that is occurring, we're going to continue to see a glut of the people in our community who could be far stronger and help make us better moving forward. So I do think that we've got to continue to build collaboration around the funding of it, access to care. How do we make it so that it's not as stigmatizing to people who maybe currently are employed but won't be for long if we don't deal with their dependency on narcotics or alcohol or whatever the issue might be, or the behavioral health struggles that they are having. So I think we've come a long way, but I also believe there is so much more to be done. And as a society, we talk about it. We're a group that's probably pretty well versed in it, but we aren't the routine. We aren't the normal people who stand around at a party masked and socializing and talking about how we get access to recovery for the people in our community. Some of our communities are still very naive and believe that if they look the other direction, that this will go away. It won't. It's only going to become more intense if we don't deal with it. So we appreciate our collaborating partners, Crossings, Gateway, Heritage, many others, and we need even more. There still are not enough resources with those that we have to meet all of the needs. And for some of the patients that we face that have great challenges, dual diagnosis, lack of financial resources or coverage, and being able to open doors when people are in crisis. At the same time that as they recover from that crisis, how do we keep them in treatment so that they can continue their recovery?
Thank you, Teresa. Dr. Burke, I asked the ladies to share about gaps, and I think you could definitely do that. But also, you have been leading the way at Will County. There's many other suburban communities that could learn from you. So if you could talk a little bit about what you see the gaps are and maybe lessons learned, maybe if other communities want to replicate some of what the innovative projects that you're working on.
Thank you. I love what everybody's saying. I think we've identified social determinants of health, determine whether someone is able to stay in long-term recovery. That requires systems of care and housing and jobs and all the components in a community that can come together and collaborate to work in this arena. I think my surrounding suburbs, I often get approached by them because they're struggling with the same type of increase in overdoses, relapses are occurring. Their behavioral health systems have had to close or just close their doors for a while because of the public health requirements. And so how do we get back on our feet and work through those things? Collaboration is probably the key. You need to gather together, and that's what we did in Will County. We gathered the agencies that are all involved with this problem. So the treatment agencies, the FQHCs, the schools, the providers of care, private providers of care, and then the county, because the county has resources, just like the state has resources. And the county affects policy within the community. And often you got to get to the rules that are preventing people from getting care, right? So I've come across things where people have been funded through grants, and there are restrictions on being able to meet a person in the community versus you come to me and you come to my office and we'll fill out the form and we'll get you started. People don't even know that they can do that. They don't have transportation to get there. They don't have a phone to call up and find out. And so it's important that collaborative effort means getting into the community and talking to the folks who are being most affected. So the recovery coaches that we've put in place in our community are lived experience. These are folks who've been in that same situation, who can speak to the circumstances and can offer that hope. We need to listen more to folks who are going through recovery, who will identify what those resources are they need. And I'll give you a good example is housing. Recovery housing is critical right now, particularly since the housing price rentals are going way up because of COVID. There are no rentals because people are frozen in their current locations. So anyone who's looking for rental housing is at a disadvantage. Communities don't understand recovery housing. They have very negative stigma around it, around the folks who are living in them. And we need to break those stigma down. And you do that we talked to the police first, right? The police are the ones who interface a lot with the clients that we're talking about and get them to see it from a broader view. The agencies need to work together and not always compete. Because I know when I turn to Gateway for assistance, because I have a client who needs to get into care, I go to all my partners and it's one of them who will have services, right? It's not because one does, the other one doesn't. Every one of you have capacity. It's whether the person I'm looking for needs that type of service and how can we best fit that ball in that hole? What's the best thing? And so we had a safe passage program. Many of you know about Safe Passage, which is a police deferment program. Well, our police chief came to me and said, this isn't working. Nobody's coming to us. Well, there's a reason for that. They don't trust the police yet, right?
Yeah, right.
So we changed that. What we have is naloxone plus. We get permission to contact the person after an overdose. We give them naloxone, and we offer a warm hand to services if they need that. So I have been at the advantage of not being restricted by standardized rules that your funding agencies sometimes put you in and the state puts you in. I have been able to work within the system, and that's what somebody needs to do. And my suburban partners work within the system. You have to navigate and move within the gaps. And the person that you're thinking about is the person who needs care, not the agency you work for, not the community you're in, but the person who needs care. And I am driven by the fact that 8 years ago, when my son and his wife needed care, I was in healthcare. I was an educator. I didn't know what to do. I didn't understand the disease. I didn't understand the services that were available. Now, I should have been a more educated person, right, in that regard, but I wasn't. So people who have no contact with the healthcare systems or systems of care, they're lost. So we can do a better job of bringing it to the surface and letting people know the care that's available out there.
That's a great point, right? We assume, the assumption is sometimes that, oh yeah, there's treatment out there, but if you don't know where to start, it's very difficult. We have about 10 minutes left. I want to give everybody a chance to just one very brief, if there's a last comment that you want to make. I mean, the point of today's conversation is to do just what Dr. Burke said, is to tell people about the systems of care, identify gaps, identify opportunities, and show that the only way we're going to combat this crisis is working collaboratively. So anybody want to share one last word? And then I'm going to ask Tom to close us off. So Ginger, one last comment from the education perspective?
Yeah, I think the last comment that I would make is I think people just generally spend a lot of time thinking about what's happening in K-12 and trauma that the children are facing and what's happening in their communities. And they forget that I heard one university president describe it this way, that trauma comes to college, that we forget what our college students are dealing with, whether they are coming straight out of high school and going to college or they're adults returning, and what people are navigating in their lives. So I think it's just really important to remember that college is like a community. It's the same as any of the communities that folks live in. And we have to think about meeting people's needs all across the spectrum, even as they're in school. It's not just like going to class, but that we really need to make sure we have all these services available and wrapped around students at whatever age they are and wherever they are in school. Thank you. That was perfect. Karen?
Yeah, at the height of the first surge in March, April, 2020. In New York, there was an emergency department physician who committed suicide. And we spent a lot of time at Sinai, Chicago, talking about, what her colleagues might be thinking. Did they just not see it? She was coming to work every single day with this terrible stress. Who knows what else was going on? And we think about this a lot. And one of the things that we put into place was having our leaders literally sit down with every single caregiver in their division to just, look them in the eye, not that they were trained, but to know if somebody would need to, be referred someplace to get the help that they need, especially during this time. And I think that that's so important, particularly for healthcare workers. I'm looking at Teresa in my little, on my little screen here, but I think particularly for healthcare workers, we're all taught to be, particularly the frontline folks, suck it up. We're going to be tough. We're here when other people aren't. But I think particularly during this time where we know substance abuse is up, mental health issues are rampant, we need to pay attention and make sure that we ask the questions and everybody gets to the help that they need.
Thank you. Teresa?
So I'll build on Karen's comment, because I think what we all have to realize is we want to think about behavioral health or chemical dependency as someone else, as that population that is outside of us. And reality is, it is us. It is our community. It is our church. It's our business. It's the people that we work alongside or that we care for. And if we don't come together and do something about this, we will continue to lose people in our community, and we will lose those who we all treasure and value that work alongside us. So I think our awareness has to be broader and recognize that it's not about taking care of someone else. It's about taking care of all. This is a disease of inclusion, and we all have a need, be that for behavioral health or for dependency of some sort. So collaboratively, we can do something about it.
Thank you, Teresa. Dr. Burke?
I just want to talk for one moment and point out the continuum we've all talked about, right? We've talked about a continuum of care that starts when children are going to school. Mental health and substance use go hand in hand, and we need to link those services financially, reimbursement-wise, so that people can get coordinated care, and they can start at a young age and they can go all the way through their lifetime. We have been limited by our insurers and our payers with lack of understanding the disease. It's time to stop that. It's time to wake up and address the real issues that are involved with some substance use or mental health and substance use.
Thank you, Dr. Burke. And Dr. Britton, will you close us off, please?
Sure. And first, I just want to thank again those on the panel. This has been a wonderful conversation, and I really appreciate, Teresa, kind of how you put together the different pieces, because we got some great representation of the different parts of the puzzle. I think the most important thing, and perhaps this is a call to action, is that At the top it says recovery for all, and in many ways that highlights this conversation, which is that everyone deserves to find recovery and everyone can find recovery, and that it really starts, however, with really the reaching out for help. And mathematically, all of us are either somebody with a substance use issue, or we know and love somebody with a substance use issue, or we suspect that somebody we love has a substance use issue. The risk of overdose death now has changed, I think, the imperative for polite conversation, that it is time that now we have to ask the hard questions and push people to get help and ask them if they're help. And if there's people that that you're worried about, ask them. If there's people in your life, don't worry about being pushy. That now is a time where everyone needs to get into care. And you don't need to be doctors. You don't need to have the answers. You don't need to know where to go or what to do. I got a call today from somebody who runs a huge healthcare national company, and they said, my daughter has a problem, I don't know what to do. And they, of all people, you would think that they would know, but they didn't, and they're not supposed to. So call somebody like Gateway or somebody near you and say, I don't know what to do, help me. And somebody will help you. And I have faith that everyone can recover. So thank you again for joining us today. Go forth and celebrate in as healthy way as you can find. Thanks, everybody.
Thank you.
Thank you, everybody.